Good morning and welcome to this meeting of the Board of Directors of Lincolnshire Partnership NHS Foundation Trust. My name's Kevin Lockyer, I'm the Trust Chair. It's our usual practice to start our public board meetings with a patient or staff story, and we're doing that this morning. This morning's story is from Neil, the manager of our Sexual Assault Referral Centre, and Emma, a service user. Really glad to have you both here this morning. Your story, I think, is really important for us to hear. It's kind of invidious to single out any of our services as being particularly important, but I think our SARC is an exceptionally important service. So I'm going to hand over without wittering any longer to Neil and Emma. Thank you very much for joining us this morning.
Good morning, everybody. Neil Wells on SARC is the manager at Spring Lodge. It's a great pleasure today that I can introduce Emma to the board. I'm not going to talk anymore. It's Emma's day, it's Emma's story. So I'll pass you over to Emma and look forward for your comments.
Good morning, everyone.
Morning, Emma.
Good morning.
Good morning.
It's really wonderful to do this. Absolutely fantastic opportunity just to talk about Neil and the service. I joined, I had a referral sent through in, I think it was February time this year, and the speed from the referral to the actual first face-to-face contact was incredible. I mean, I know all about waiting lists because I work for LCHS myself, so it's all completely, I know sometimes it can not be as, in the media, it's not always perceived as a good waiting time and everything, but this was fantastic. I must be honest, however, from the beginning, I thought, oh, it's a man. No offence to you males that are listening this morning, but I wasn't quite sure how that would work. I assumed it would be a woman that would be sort of, leading this kind of service, but I was really pleasantly surprised with Neil. He is absolutely fantastic. I'm not just saying that because he's sat next to me. He has helped me and my family through what has been one of the most horrendous experiences of our lives. It's been a rough few years with one thing and another, but particularly this type of thing, it's very difficult to talk about. It's not something that you can just speak about to anyone, but Neil made it so easy. There was no judgment, there was no sort of plan to face-to-face meetings. It was literally just talk or not talk, walk in and be whatever you need to be, and that was absolutely fine. But also the wider sort of guidance and advice that he gave me was, second to none. And it'll be difficult for him because he's so, I know he's sat there laughing at me now, but he doesn't understand how fantastic he actually is. He supported me in court for 3 days, which would have been a much tougher experience without him, and to actually get the outcome we needed in court as well. And for him to share that with me and some of my history and the family's history I think it helped us along with everything else, and definitely having his support there made all the difference to me. And I can't thank him enough. On top of that, also, I must add that there were some coping mechanisms I've not heard of before, despite working for the NHS and knowing certain mental health teams and whatnot. Neil made me think of things a different way. And the whole team there already loved it. When you walk in, it's just morning, how are you, and that's it. And that makes such a difference. You feel so calm walking into the actual clinic or whatever you want to call it, that actually you don't feel sort of strange walking in. Everyone's nice, and that's the difference. In some places it's not like that. Even in 2021 it's not like that. And I would recommend anybody that could sort of has been through anything as severe as this, it's a horrible thing to go through, but it's made a little bit easier by staff and people like Neil who just make it an easier experience. And I honestly can't say enough good things about him. He's just absolutely wonderful. And the ongoing support as well, because when I get discharged from Neil's caseload, there are some other things that we can join. So like a monthly lived experience group and things like that, which again, it might get more people talking. It might get people to keep that bit going. Once you get discharged, there's often a gap in the service, and it's nice that something else can maybe be brought in from that, and to talk about our experiences together and just keep that bit of support there for each other as well. I just think, you know, it's literally, but like I said, the biggest thing for me was the referral time and face-to-face contact. I thought I'd be waiting months, but it was so fast. And if it wasn't for that, the fact it was quick, and I got seen to quickly and spoken up to, and it was like the whole system was flawless. Without that, I don't think I'd be where I am now. I took 6 months off work, which was Neil's fault. He was saying, you know, how's it all going? And I just went in one day and I wasn't coping, but I didn't want to admit it. I also didn't want to let my patients down working in the community. We've got quite a tight service in the therapy service. It's not very well staffed, so I felt guilty about taking time off. But then the actual support from my managers as well in LCHS was incredible. You know, the safeguarding team, Tom Roche, who's the head of adult community therapy, he actually joined us in court as a witness statement for me. So from across the whole board of NHS, through mine and from this experience with Neil, it's been incredible. So if anyone's got any questions or anything, I'd love to answer them.
Thank you very much, Emma. I'll hand over to my board colleagues to see if anyone has got any questions or comments. Well, there's a question from Sharon.
Morning. Excuse me, got a bit of a cough. I just wondered around, you mentioned earlier, you know, your family and how difficult it was for your family. And I just wondered if they were able to access any support.
Not through Neil directly. Obviously, my children are both school age, so the school were all involved in all of the ongoing issues, really. So they've had, it's more my little girl because my daughter's 10 and my son's 5, so she's obviously seen and been around a lot longer than my little boy. So yeah, she's had access to counselling at school for the domestic abuse side of it, and she had a EDAN support worker as well, which, you know, for the Rainbow Foundation bit of there, which is the children's side, and without them, again, you know, it's a much better place with them.
Okay, thank you.
Thank you.
Thank you, Sharon. Sarah.
Thank you very much for coming along to board today and telling your story. So, and you're very complimentary, and I don't know whether Neil's crossed your palm with silver or something, but you're very complimentary. Hi Neil, nice to see you again. Is there any learning, do you think, for us or for the court process or anything that could have been done better, do you think? Sorry to put you on the spot.
No, it's absolutely fine. I don't think there's much that could be improved, if I'm honest. We just need to clone Neil.
I say that about a lot of our staff. If we just had a cloning machine, wouldn't be wonderful.
No, there's nothing. I honestly don't think there's anything that could be improved. Like I say, the waiting time is perfect. There's no rush to be off the system to be discharged. You know, you kind of, it's at your pace, and that's what makes this service, you know, fantastic.
Great, thank you very much.
Thanks.
Thank you, Sarah. I may have missed it, Emma, but you said you know, the waiting time was great. How long did you wait between referral and first?
It was under 3 weeks.
Okay. And do you think? Sorry, this isn't a trick question or anything. Do you think your view of that waiting time is you're seeing that through the perspective of, you know, what you expect NHS waiting times to be? Or do you think that 3 weeks objectively about right? Could you know, if you'd been seen sooner, would it have been too soon?
I think because when the first telephone triage bit came through, we was given a time of when we wanted to see somebody, so it was more like you know, you could now or in a couple of weeks or whatever. But because I know our waiting list for therapy, it's a different service, but still we've got an 18-week waiting list, and a lot of mental health services and other places can be a lot longer than that. So as a general rule, really, because I work for the NHS and because I'm a patient, if you like, it was kind of a joint approach. I thought it might be a little bit longer than that.
I mean, I think just an observation. I think it's a shame, in a sense, and this isn't a comment on this service in particular, Neil or Emma. It's a shame that we've become so used to long waiting lists that 3 weeks seems, very, very short.
Yeah.
And I'm glad that we have a responsive service, but I'd be even happier if we thought that 3 weeks was a long time. If you understand what I mean.
Yeah. I don't think.
It's been a hard term in that week.
Yeah, there was, because I think I deferred it a week anyway because of half term. But honestly, I think it's a decent waiting time.
Yeah,
and I think,
I'm not arguing with you at all, Emma. It's just a wider reflection. Let me move on. Anita.
Hi, I'm a comment before I come on to a question. I mean, I think just in case colleagues don't know, I mean, I was part of the original team that made the decision to kind of support the SARC coming into LPFT, and we do something very different in Lincolnshire with our SARC than anywhere else, and it being aligned to a mental health trust kind of, and that joint work, and I think it absolutely shines through. And I agree. I think Neil's probably crossed your palm with silver. But no, and I've seen Neil at work. It is incredible. My question is, in a time, and I kind of lead safeguarding in the organisation, so we know kind of nationally in times of COVID, that there's a huge amount of increase in incidents. And it's probably more a question for Neil, and I'm going to put you both on the spot really, but how can we get that message out to people that aren't coming forward about the positive experience? And there's no need to be frightened, because I spent a lot of time in the SARC, and I do know what it's like. From the minute you walk through the door, it is a very beautiful, safe space, and it's how we can share some of that message and get more people coming forward. I did neither. Sorry, I'm Anita Lewin. I'm the Director of Nursing here at LPFT. I've just seen Sarah's messaged us to say she didn't introduce herself, and I did neither. But it's just how we can share some of that, so people that are frightened to come forward, we can kind of share some of that story and that message.
Yeah. To answer that, Anita, for me, I think more stories like this need to be out there. Emma's brave enough to come forward today, and I think if we get more and more people involved with that, and celebrating what we can do as a service, so more and more people feel brave and able to come forward, in a non-judgmental way and things like that. I think maybe there's more we can do on the media side of things as well. As a trust, perhaps specifically within the SARC. I don't know what you think, Emma.
Again, I think there's lots of information on the employee staff site about domestic abuse. There's things like that, but there's not much about the SARC side of things. So perhaps for colleagues, if it could be added onto the staff site, so there's access more readily available, and people can sort of think, actually, this is okay to do this.
I'll contact you outside of here, Neil. There's probably something we can do with the Daisy staff group and work around that. I'll give you a call. Thank you.
Okay. Yeah.
Thank you, Anita. Di.
Thanks, Kevin. Thanks, Emma. I'm Di Bailey. I'm one of the non-exec directors. Can you hear me okay?
I can, that's good. Yes, thank
you.
Okay.
So thank you for sharing your experience with us. I took away 3, I think, really important areas of learning, and I'd just like to kind of explore those a little bit more with you, if I may. So the first one was how you started, and you said, you were surprised that Neil was a man.
Yes.
And I think sometimes when we're trying to respond to issues that relate to gender or ethnicity, we think that it needs to be a practitioner that has the same gender or has the same ethnicity. And actually, I think it's more about those skills in terms of making people feel safe, people feeling non-judged, as you said, giving you that opportunity to talk. And I just wonder, is that right? What is it that makes the difference in terms of, that sort of, in a sense, it's more important about the capabilities of the person than necessarily whether they're male or female or. black or white.
I think for me, because obviously I'm not usually a judgmental person, but this time I'm the patient and I'm thinking, well, how can a man possibly? I didn't like men very much, I'll be honest. I was like, at that time, I've been through an awful lot caused by a man, and it was like,
Yes.
How could a man actually understand my feelings in this? Being the fact that, you know, it's like sometimes at EDAM, most of the support workers there are female. They've been through the same sort of thing. Of course, domestic abuse can affect anybody, male, female, whatever.
Yeah.
But particularly in this, it's quite a sensitive subject to talk about. It's quite embarrassing at times. It's quite in depth. But because Neil has the qualities of not only listening, it gets me to talk without knowing I'm actually doing it. And we talk about things that initially bring out one problem, but might flourish into a few more. And that's what makes this service so special, because you don't walk in there talking about one thing, it issues other things as well that might be going on.
Okay, I think those skills are really important for us to hear that. The other thing I heard you say was about joining the group post-discharge in terms of the lived experience, and I wondered there about that. You're right, there's something really important there about when people leave the service, that it doesn't just stop, that there's some sort of step down. And I wondered about your thoughts around peer support in that space.
Yeah, I think it's a fantastic opportunity. I mean, I used to do health and safety training. I used to run a group for that, and I'd love to do something like that within NHS somewhere. I've spoken to my own safeguarding team at LCHS should an opportunity arise, but I think you know, we need to be sticking together, as it were. Once we're discharged, there's a nice group there to keep things going and to be involved with other things that might, you know, a monthly meeting, Neil was saying, and opportunities to perhaps sit in on interviews and ask questions of, you know, prospective employees about what we think is important to join that role.
Okay, that's great. And finally, if I may, and apologies, Chair, for indulging me, the last thing I heard you say, Emma, was about the time that you took off work, and that was really important in terms of giving you the space to do what you needed to do to kind of get back on track.
Yeah.
And again, I just wonder what advice you'd give us as service providers to plan that with individuals, because I think sometimes we just expect people to come into services and respond and do what we're asking them to do without recognising that sometimes they need that sort of psychological space to take stock and get back on track.
Yeah, absolutely. It's literally, I didn't know I needed the time off. I was just working, carrying on doing everything as I normally would, like hamster on a wheel. Bit of a cliche, but that's how it was. And it was only going to see Neil. Nobody else could tell me to take time off work, or advise it, should I say, because I just, no, I wasn't buying any of that. But it's different when Neil put it in a different way. So he spoke to me as an NHS worker. So how would you feel if you wasn't giving your best to a patient? Well, that would be the ultimate no-no for me. My patient care is top priority. And after I realised that I wasn't on top of my game, that's when I needed the time off. So it was a different approach to get me to take that time off, and it worked.
Great. It's really good to hear. Thank you so much. Thanks, Chair.
Thank you, Di. Always happy to indulge you with insightful questions and comments. Tim.
Morning, Emma and Neil. So I'm Tim Harry. I'm a relatively new non-exec director, and one of the pleasures of the job is actually going out on site to meet people. And Neil may or may not remember that I had a site visit to Neil and the service, and really my comment really is just to endorse what you've said, to probably embarrass Neil a little bit more. The thing that shone out to me was some of those interpersonal skills which you've relayed, and there were some insights in terms of how Neil works with his team, which I was very impressed with. So that may explain, you know, the whole team and the way that you were received. So really, it's just to not deliberately embarrass you, Neil, but I think your interpersonal skills need to be recognised and acknowledged.
Yeah, I couldn't agree more. Definitely.
Thank you very much.
Thank you, Tim. It falls to me to bring this to a conclusion. Emma, I just want to say thank you very much for, it takes a degree of courage to come and talk to a bunch of strangers, even if it is through a computer screen, about the services that you've experienced, and particularly given the circumstances in which you had to access them. So, thank you very much for sharing your story with us this morning. It's really important for me as chair, really important for the board, that we hear firsthand from our patients and service users and understand exactly what they've experienced, whether that's good, bad, or indifferent. It's really, heartening to hear this morning that your experience has been, a wholly good one. So, that's great. And the reason for that, Neil, is because you run a great service. I've had the same privilege as Tim and come and spend some time with you. It is a great service, and on behalf of the board, thank you very much. If you weren't running a good service and you weren't running it in the way that you are, Emma wouldn't be telling her story, and we wouldn't be having the kind of positive feedback that we've got. So thank you very much indeed. My final comment is, it is a great service, and we do something different with SARC in LPFT that other mental health trusts don't. And the thing that I'm keen to do is to ensure that the rest of the trust services learn from what you do really well. And we had that conversation when I was with you the other week, Neil. It's a conversation I've continued with others in the trust. So, I'm determined that where we have really, really great practice, that we understand what makes it great, and we share that across the rest of the organisation. So thank you very much, both of you, for giving up your time this morning and joining us.
Thank you.
Thank you. Thank you all.
Thank you.
So let's move on then to our routine agenda. Have we got any apologies for absence? Don't think we have.
Kevin, it's Peter, just to say Ananta's joining us late.
Ananta's joining late, yeah.
Yeah, and Di may have to leave early.
Yes. No, I was aware of both of those. Declarations of interest, are they as published or any changes? I know that you've got a change to your role title, Di, which I've picked up separately, so we'll make sure that's reflected next time that's published. Minutes of the Board of Directors meeting on the 4th of November. Does anybody have any comments on points of accuracy or any other matters arising? I don't see any. Are people content for me to sign those as an accurate record of that meeting? Thank you, Sharon. Excellent. We'll move on then to the schedule of actions, item 1.4. We've got 3 open actions with updates on them in the schedule. Has anybody got any comments or questions on either the open actions or those that have been completed? Again, I don't see any, so I shall move on. For information at item 1.5, there are the minutes of a Council of Governors meeting held at the end of October. I'm happy to take any questions or comments on those if colleagues have any. I don't see any. So we'll move on to 1.6, which is going to be equally brief. And then my remarks. I'm not going to make any remarks that kind of stand on their own, because most of the things that I should have wanted to have said, Sarah is going to say in the Chief Executive's comments from the next board meeting. I've given into the temptation to write some remarks for the board, but I promise that they will be brief and probably not longer than a side of A4. So next time I will write something in advance. but for now, I'll forego the opportunity to add anything that the Chief Executive would otherwise pick up. So on that note, then we'll move on to item 2.1, and Sarah, your report, please.
Thank you, Kevin. Morning, everybody. I'm Sarah Connery. I'm Chief Executive here at the Trust. So this is my report to give a high-level overview of key national, regional and local issues. So a bit like yourself, Kevin, I try and keep it brief, and I set myself a target of keeping under 10 pages in terms of my update, but there is so much going on. It was a struggle this month, but I will assume the paper is read. As with usual, we start with COVID-19, and it won't have skipped your attention that we're starting to deal with the effects of a new variant, and also the tension, if you will, between what's happening in wider society versus what we need to make sure that we're staying vigilant around in terms of infection prevention and control within the Trust. We have had some outbreaks since the last board at the Psychiatric Intensive Care Unit and also the Psychiatric Clinical Decisions Unit. The outbreaks were well managed by staff, and we continue to learn lessons where we can to prevent reoccurrence. It's noted in here, just to point, because it may come up to the board in future, about our local acute trust are actually revising their risk assessment for movement of patients following COVID exposure from 14 to 10 days. At this moment in time, we don't believe this is a requirement for our trust, but we're going to explore this further, and potentially it will come through the quality committee up to board if we decide to take that decision in terms of dealing with activity pressures. We continue to work through the implications of mandated vaccinations for professionals visiting care home staff, and so far no significant service impact has been felt from that. We continue to monitor the position closely through Silver. The key point for us this week, which we're spending a lot of time as an executive team working through the implications and importantly making sure our staff are supported, is around the announcement for mandatory vaccinations for all frontline healthcare staff from the 1st of April 2022. We continue to cleanse the data. It might sound a bit surprising, but it isn't actually straightforward in terms of getting a data cleanse list. So working really hard to make sure we've got correct data. At the minute, we're 53 staff confirmed without a vaccination. A number of those are pregnant ladies who are intending to have the vaccination post-birth. But what we're hoping to do, working really closely with our service lines, is make sure that people are supported to take an informed decision, and we're just working through that again. I'll keep the board updated on that. We continue to push forward on our flu vaccination. At the time of writing the report, 55%. We're aiming for 100% of frontline staff where it's relevant, so we'll continue to push that through all available channels. I've put in there about the COP26. I'll pick that up in more detail under item 2.4. We're at a bit of a pivotal moment, I think, as a board in terms of our approach around the green agenda. We discussed at last board about the half-year 2 plan, which has been a really great piece of system working. A big thank you to our Director of Finance, Mark Platts. I've also included in the report about his substantive appointment, so congratulations, Mark. In terms of working with system colleagues and in getting as good a position as we can get for LPFT for the last 6 months of this year. In terms of region, it was too late for the position in terms of this report, but we did have an East Midlands Alliance board on Friday, which was really positive, talking about working together in terms of addressing our workforce challenges as a region as opposed to siloed systems. And a real important crux point, I think, for our alliance in terms of if one fails, we all fail. So we need to work together as opposed to bunkering down, but there'll be more on that at the next report. In terms of the Lincolnshire Alliance, we had a timeout session with district councils, care sector, voluntary groups, primary care and other NHS partners to talk about how we're going to work around primary care network footprints with a particular focus on end-of-life care. to really improve experiences for frail elderly out in the community. We continue to be rated as Soft 4 as a system. That's the system oversight framework. And as we talked about at the last board, capacity continues to be an issue for transformation, but we have got a very detailed plan going forward, and we are out to recruitment for additional transformation resource around the 3 areas of focus, which is elective with a focus on musculoskeletal, prescribing, and care close to home, which is obviously quite a large umbrella for a number of different service lines. System chief finance officers have been working together really closely on a risk and gain share approach, which will be discussed in part 2 of the board. And we're working together to build up our Lincolnshire Health and Care Provider Collaborative in terms of the vehicle for the service transformation, and not just through the recovery support programme, but beyond into the future as well. We've had some really positive visits to Ashviller and Brantwood from the CQC in terms of Mental Health Act inspection. As with most visits, there are some actions for us to address, which the executive team are well aware of, and we're already addressing some of those. Were sort of quick wins within the week, but other areas we're addressing in terms of the action plan, and also ensuring that we're picking up the learning from that in other areas as well. There's some information on page 5 about the Winter Precious funding, so enhancing the psychiatric clinical decisions unit to pilot a bit of an open door mental health assessment centre, which will accept walk-ins and police and ambulance handovers. So really excited about this, and we'll make sure that we do a really robust service evaluation in the new year to see whether it's something that needs to be progressed. Also working with our voluntary sector groups to expand the crisis cafes across the county as well, making sure that we're putting community assets in those areas, particularly on the East Coast, which haven't been as well supported as, say, Lincoln and Boston areas in the past. We're also rolling out our carer champions. The board has had a lot of updates around the benefit that we see from these really important roles. So we're making sure that we've got coverage of the care champions across all of our inpatient facilities. We've talked also in the past about at the board about transformation capacity within our own organisation, and there's some information there about additional posts that we've put into each of the divisions and within the community mental health transformation programme to make sure that that's bolstered. It is Disability History Month this month, so there's a number of virtual events that are going on to show our support, and we've been really pushing the Maple Staff and Allies Network for staff to make sure that they've got their experiences heard and that we can learn from that to improve working practices. There's also been a number of high-profile cases in the media recently about ongoing institutional racism in our society. I just want to push again, I talked at the last board about the See Me First badges, so if anybody is interested, please get in touch and we'll make sure that a member of the board, or in fact any member of staff at the trust, can get one of these. So with a 6 trust to sign up to this really important campaign to show that we will not accept any form of racial discrimination in our services. In terms of celebrating success, finally, so we weren't successful in winning the Mental Health Trust of the Year event. Congratulations to Somerset, who win, a very worthy winner, but we're just so proud that we were a finalist for the 2nd year running. It was great to have our achievements showcased, so a massive thank you to all the staff, as always, for getting us to that quite coveted position. Our research team was shortlisted for East Midlands Research Awards for Outstanding Achievement by Team, so congratulations to those. It's a bit too late for the report, but we were also successful in winning the Children and Young People's Now Mental Wellbeing Award for our Complex Needs Service, which is a great piece of partnership work with local authority around trauma-informed care, which is really great news for the service. We've also had our individual placement service review, so that's like a re-accreditation, really quite stringent assessment process, Again, it was too late for this report, but we have had initial feedback that we've achieved a good rating on that. So a massive thank you to Sarah Bruin and the team for getting us that position. There's also something there about the accreditation for the Carers Quality Award. And we've got teams accredited there which are listed, but it does get rolled out to other inpatient and crisis teams as well. So we'll keep you fed back on that. And that's me done. Happy to take any comments or questions.
Just an observation, Sarah, and it's a without wishing to sound patronising, it's a really good report that does summarise an awful lot of activity in a concise and readable way. So really grateful for that. The second point is, just to dwell on that point, there really is an awful lot going on at the moment, and from the chair's perspective, I'd remain exercised by the senior leadership team's ability to keep the wheels on the bus, as it were, and deal with all of the system and other developments. And I'm not flagging that as an issue for discussion this morning because, Sarah, it's something that you and I discuss regularly bilaterally, but just from the board's perspective, just to note that that's an issue that that both Sarah and I, on behalf of the board, are focused on and aware of. And the third thing I just wanted to add was, because I didn't do it, I could have done it under my remarks if I'd made anywhere, is just to add my congratulations to Mark for his substantive appointment. Well done, Mark. Tim, I think you have a question.
Hi, yes. So Tim Harry, non-exec director. Hi, Sarah. I know we're meeting up around PPM resource, I think, in the next sort of couple of weeks. I've just got one quick question, because otherwise I'll forget. Do we ever tap into the NHS PPM network for resource? And the reason I ask that is quite often there are people who are looking for opportunities to be seconded somewhere for a period of time.
It's not something that we've progressed before, so I think that's an excellent avenue that should be looked at, and it's something that we've started to actually ask for help, because we have offers, but I think sometimes there's a bit of a we're all right, we're okay, we'll just cope, rather than reaching out and taking on the not just additional capacity but capability, I think, as well. So It's certainly something that we've looked at in terms of tapping in through NHSEI regional teams, for example, in terms of their capacity and capability. And you do find, actually, when you put it out there, as you just said, that people are really interested in getting involved in systems in more depth. So yeah, maybe that's something that we can pick up at when we meet, Tim.
Yeah, I'll dig out my my source information.
Thank you.
Thanks, Tim. Don't think I have any other questions or comments. I can see that Ananta's typing furiously, but I don't know whether she wants to ask a question or make a comment, so I'll tread water for a minute until I find out. Ananta.
Thank you, Chair. Good morning, everyone. Ananta Dave here, Medical Director. Just wanted to say apologies for coming in late. I was welcoming trainee doctors to our trust this morning, and I just wanted to add my congratulations to Mark Platts for his substantive appointment and for a comprehensive report. Thank you.
Thank you, Ananta. And you were doing important work this morning, so much more important than attending a meeting of the board. So thank you for that. Great. Thank you very much, Sarah. And thanks again for a comprehensive report. And thank you on behalf of the board for the work that you're doing to help to lead us through this complex and busy time. Let's move on then to item 2.2, which is the refresh of the trust strategy. And Jane.
Thank you, Chair. Good morning, everyone. Jane Marshall, Director of Strategy at Lincolnshire Partnership, here introducing a very brief paper that refreshes our overall high-level trust strategy for the remainder of this financial year. So you'll see from the documentation, we've managed to put a very high level summary of our trust strategy onto one side of A4 so that we can all of us just be reminded of our focus for the remainder of this financial year. This high-level strategy reflects the 3 strategic ambitions or pillars that we have as part of our assurance processes as an organisation, and those are around the people, sustainability and quality. Each of those assurance committees are chaired by a non-executive director, and what we've put on this document at the bottom of the document is those key targets, very high level, or metrics that we use to monitor progress. It isn't the full set, but it's a very high level summary of what we focus on as a board of directors. This strategy will be refreshed for an April 22 start as part of our business planning processes that are about to commence. And here for approval, Chair, today. Thank you. I'm happy to take any questions.
Thank you very much, Jane. My observation is simply that is to commend the brevity and and focus of this. It does the job really well without taking 47 pages, and I appreciate brevity, so I'm grateful for that. Tim, I think you've got a question.
Yeah, it's an issue one. Hi, Jane. Thanks for that. Can I just double check, clarify? So the refreshment that you've done is around the presentation. It's not actually the detailed content behind it, if you see what I mean.
That's correct, Tim. So this aligns with the previous strategy, but that was updated a while ago, and obviously we've had the pandemic since. But you're absolutely right. This, particularly the 3 supporting strategies, were engaged upon, we consulted upon, and so it all is just refreshed in a single page.
Yeah, great, thank you. And I think that's a really good way of presenting it. Thank you.
Thanks, Tim. Sharon.
Thank you. Sharon Robson, non-exec. Morning, Jane. I thought that the paper was very concise and clear, particularly Appendix A. I loved that and wondered if other staff could get access to that, because that clearly sets out what our priorities are. The only issue I have with it is because it was a refresh, I decided to refresh myself, go back and look at our strategy and the priorities around it. And as you said, this is succinct, and it's our recent activity. But there was a really good part in the strategy which sets out our priorities in their entirety very clearly. And I wondered when we were going to actually, as a board, get an update on that suite. So it's around specialised services, acute urgent care, older people and frailty, and adult community. You probably remember, Jane, it's set out in the strategy as a one-pager.
Thank you, Sharon. It is indeed. So in answer to the point about how we communicate the brief strategy with our people, it's the ambition, and Sarah asked me to do this, to produce a credit card size summary of the strategy so that staff can have that on their lanyard. So we'll put that in place. Yes. And on the second point about the wider strategy refresh, I think you're right. There were elements of a longer document, the previous strategy, that provided a lot of detail that we do need to refresh. And I would anticipate that is done in 2 ways, really. First of all, through our board development sessions, and I know we're having a conversation in January about our ambition as an organisation. And secondly, through the business planning process, where we would ordinarily review the objectives we set ourselves in the business plans for last year, which of course were linked to the strategy, and refresh and renew those going forward. I was really struck this morning by the patient story. there is a risk, isn't there, that in creating a very high level document, you miss some of the richness of the detailed service delivery that we offer as an organisation. So we will make sure that once the information is refreshed, that's available, even if it's not part of a strategy document, if that makes sense.
Yeah, thank you, Jane. That's great.
That last comment's really important, Jane, and it makes perfect sense. There's always, you know, a kind of tightrope to be walked here, isn't there, between, on the one hand, the temptation to put everything that we do and everything that we think is good into a strategy, but then being able to present something that people can wrap their heads around, and that can genuinely inform what they do every day. And, you know, my instinct in these things is always to err on the side of brevity and to give people something that they can carry in their pocket. If that misses bits of detail, then sometimes I think we just have to live with that and be more concerned about the overall message. But that we can have plenty of discussion around that when we come to, you know, properly refresh the substance of the strategy. I've got Di and then Sarah. Di.
Thanks, Kevin. I think actually it's just to echo what you've said. I guess looking at this in the light of Sarah's report, and just thinking about the complexities that colleagues are dealing with in terms of you know, the pressures within the system, but also thinking about the last you know, 18 months with all things COVID. I think it's a really sound approach to go back to the fundamentals of what are we here for and what are we doing. So I think that clarity of message, and appreciate that we can put the granularity behind that in other ways, is really important. So I just wanted to make that comment. Thank you.
Thanks, Di. Sarah.
Hi, Sarah Connery, Chief Executive. I just echoing other people's thoughts really, and commend Jane, because I did say simple, what can fit on a credit card. I think it's quite powerful where we can wield our values credit cards around, and it fit, you know, literally sort of close to your heart. I know that sounds a bit sort of motherhood and apple pie, but you know, it's the board to set the strategy. It's for the board to set the strategy, but it's for the staff to own it. And I think the more simple you get, the more likelihood that people will own it, and that in terms of the pillars of quality, sustainability of finance, there's lots of priorities, but the power of that is that should be aligned to the services as well. And by that I also mean corporate services, whereas the strategy, if it lifts us up, we won't have to keep doing the refresh because it stands the test of time if it's simple enough. And agree with what Sharon said about the you know, our vision is to support people to live well in their communities, and it is a story so far because there's more that we can do, but I think there's some real power in those 2 pages in terms of how far we've come since 2016, and indeed learning for other parts of the system as well, in terms of how it can be done if there is the ambition and the innovation and the risk appetite to try something different and pilot and learn and move forward. So a thank you to Jane.
Thank you, Sarah. And Jane, before I summarise things and bring this brief discussion to a conclusion, I think there's another comment that you'd like to make.
Thank you, Chair. It does fit with what Sarah's just said, actually. You'll see in Appendix 2, for the first time, we've tried to look back, and I commend my colleague Chris Higgins, the Director of Operations, for producing this. It is a really powerful set of metrics. I think it links to what Sharon Robson, our non-exec director, said about how we tell the story and the narrative of where we've been and how we want to apply that learning into our future planning and strategy. So it tells a story really through the graphs of how we've successfully managed through our operational teams to do the right thing in creating a balance between community-based provision and inpatient hospital-based provision across a range of service lines, and that we benchmark really well against other organisations. Of course, we still have to make sure we do it safely, wisely, quality standards are still met, but I think it's just a really good illustration of how we use data to support our planning. And I don't know if my colleague Chris wants to add anything to that, but I just wanted to thank him for pulling that together for us. Thank you, Chair.
That's great. Thank you, Jane. I'm going to draw the conversation on this to a conclusion, Chris, if you don't mind. Just with a couple of comments. The first is, as I've said, Jane, really commends the presentation of this. It's really well presented, it's really crisp, it's readable, it's understandable, it tells a really good story, and I'm really grateful for that. And as Tim has said in chat, the transformation over the last 4 or 5 years, is there graphically for everybody to see, and it's profound. And I just want to plant a thought in your mind, Jane, in advance of our board development discussions around the substantive refresh of the strategy, and that is, this strategy understandably focuses on what we deliver as a trust. It doesn't say very much about what we do more generally to improve mental health outcomes for the population of Lincolnshire. So that's about, kind of system leadership and, the ability to support voluntary sector organisations and so on. So I'd like us to start thinking a bit more about that when we move into, how we refresh this strategy and to start to think strategically on a slightly broader horizon. But this is great. Thank you very much. Let's move on then to item 2.3, Peter, and that's you and the Governor and Membership Strategy.
Good morning, I'm Peter Howie, I'm the Trust Secretary. This membership strategy has been now seen on a few occasions. Most members of the board saw it when we took it to the Council of Governors in its previous sort of final draft. The paper describes how over the period of the last 7 or 8 months we've consulted really widely on the content of this, and rather ironically we changed our consultation methods because of the restrictions of COVID, and that has meant we've been able to engage far more people than we've ever engaged before. We've had a number of Teams type calls with members, with the public, and sought advice. So this is a co-produced document now. At Council Governors meeting, there were comments around some of the presentational, grammatical, and checking numbers. All of that's been done. This is the version that's now proposed. I think I've had one potential amendment just to the contents page, so that the last point on there shouldn't just say tables, it should actually say membership data or something of that sort, which we'll change it to. Otherwise, this is a strategy. Only the board can approve strategies for the trust, so it is here to receive any final comments and please to be approved.
Thank you very much, Peter. So the board's invited to approve the strategy. Are there any questions or comments? Tim.
Hi, thanks. Peter, there was just a couple of things. One, I don't know if it would help just to have a very short and high piece around why the context of mental health, the sort of high level motivation piece, the importance of mental health and what's happening in that sort of field. The other one is really quite a detailed one, which was part of our discussion with the joint board. On page 8, it talks about governors' skill sets, because that was something that came up. So it's mentioned on the column on the left. I just wondered if there was a specific action on the right-hand side to reflect explicitly picking up and utilising governors' skill sets in the most in the best fashion possible. It's implicit rather than explicit.
I'm just trying to look across the sheet.
So it's the priority collating relevant data that adequately informs governor training requirements, and it talks about utilising governor's skill set, but there's not a specific outcome that relates to that.
Okay. We'll find a way of just putting an outcome bullet point in. Yeah.
Thank you.
Yeah. Okay. We'll do that.
Thanks, Tim. Thank you, Peter. Are colleagues happy then to approve the revised governor and membership strategy? That's great. I see plenty of yeses. Thank you very much. Thank you, Peter. We'll move on then to item 2.4, which is you, Sarah, and the Trust Green Plan.
Thank you very much. So Sarah Connery, Chief Executive here at the Trust. So the purpose of this report is to seek the Board of Directors approval for the Trust's 3-year Green Plan, taking us up to 2025. As has been previously reported, we need to submit to NHS England an improvement, a Green Plan by the 14th of January. We were intending on having an extraordinary board to be able to do that, but we've pushed forward and ploughed on. So I'm delighted that we're able to sort of bring it to the board here today. I would ask that you focus on content rather than presentation, because we can work some presentational magic on it at a later date, but it was just making sure that we've got the content approved. And happy to take any comments and questions, but I just want to start by saying, really, I think this is a bit of a pivotal moment for us here at the board, because this is setting us on our journey to reducing our carbon footprint net zero by 2040, but with quite an ambitious target of 80% reduction by 2028 to 2032. And you know, I think I'm safe to say that none of us sitting around this screen today will actually be here at that point in time, but needless to say, we need to take action today to make sure that we're on the right trajectory for achieving that target. So the plan highlights how we're going to reduce our carbon footprint based on 1920 baseline by 60%. So it's quite a large shift over those 3 years, and there are some key actions, particularly by the changes in our utility supply in terms of getting that down, and that equates to nearly 3,000 tonnes of carbon on an annual basis being reduced in achieving that target. We are working together as a system to be able to do it, because we have to do our integrated care system green plan by the end of March. So we need to make sure that we're aligned and we're working together and pooling resources wherever possible, particularly around areas of estate medicine supply and procurement. So I just want to put forward the plan, and I'm happy to take comments and questions so that we can get the document ready for submission on the 14th of January. I'm afraid it hasn't been through the Sustainability Committee because of the timing, which it ordinarily would be. But once the plan is approved, that's the how the smart action plan which we're developing will be monitored and measured going forwards. Thank you.
Sarah, a quick question from me. Is there a prescribed format in which we have to submit this plan, or do we have entirely free rein with what we do?
No, as long as we've covered these specific headers, which you can see on the areas of focus, and we've got a specific vision for each of those headers, then we've sort of ticked the box from a NHSEI point of view.
Okay, I'm grateful. Thank you, Sarah. Sharon.
Thank you, Sarah. I read this with great interest, and you know, our target is very challenging. There's just one bit in the plan where I wondered if it would help to contribute to that target, and it's under 5.6 medicines, because I'm aware that something like 80% of medicines are in blister packs, and I wondered whether that should be one of our actions that we should look at, you know, companies that we work with in terms of reducing the use of blister packs and those kind of things that also aren't good for the environment. So I know we've covered aerosol use, but the wider issue for us would be the packaging of medicines generally.
That's really helpful, Sharon. I'll make sure that gets fed back to the group, and we'll look at putting that in as well. Thank you.
Thank you, Sharon. Tim.
Thanks, Sarah, for the plan, and fully support and endorse it. I think I almost have to declare a conflict of interest, not conflict, but declaration of interest, as this is one of my passions. Kevin, if I get arrested on a march, I'll let you know why I'm not at the next meeting.
I'll stand your bail for you, Tim. It's all right.
That's very kind. Thank you. Just one thought or maybe suggestion, and because it doesn't really relate to the scope of the trust green plan, but there's a section in there, isn't there, about helping staff with sustainable travel to sites, etc. I don't know whether perhaps we could extend it to providing staff with other sources of information on a broader perspective about green plan in terms of what they can do as individuals, not necessarily in the trust sort of context, but there's some really useful sites and information around nowadays, to help people practically do stuff. And I think that's just another facet of our commitment, because we can do what we want with the trust and succeed in that, but if everybody else doesn't do their bit as well, then
Yeah, absolutely. I think that's a really good point, and there is actually, it's a piece of work that's been taken forward through the regional green board, and then there's a national green board as well, because there is actually an ESR module that people can do, and I think some trusts are even mandating it for every member of trust to complete that. I didn't feel that was something relevant to put in for this particular 3-year plan. But what we haven't really got going with at the minute is our Green Champions role and what that will look like and how it will disseminate across the trust. So I think that's definitely something in terms of the resourcing going forward. We've just got our comms and engagement input to the trust group and the system group as well. And I think there's a role to play there as well. It's, these are the resources that are out there to live a more sustainable life.
Yeah, thank you.
Thank you.
Thanks, Tim. And I think I've got Andy next.
Morning, Andy Spring, non-exec director. Morning, Sarah. I guess I'm with Tim, but I'm not quite on the demonstrator kind of mode yet. I just wondered what would need to happen for us to be even more ambitious. One of the things we put is 2028 to 2032. What would need to happen for us to put 2028 instead of a range of 4 years, for example?
No, that's a really good challenge, and I'm not equipped at the minute to be able to answer that. But I think as we approach the middle of or end of this planning period, I think then things will become a bit more apparent in terms of the decisions that the trust might be faced with, because there's a balance inevitably, isn't there, in any of these decisions between sustainability and finance and the impact on patient care as well. But I think that the wheels are already in motion, if I'm honest, Andy, in terms of that, because I think sustainable pathways of care are actually one of the big hitter areas as well, and in terms of the footprint of our population, in terms of how they interact with our services as well, and the standard operating procedures that Chris and his associate directors are working through in terms of, at what point do we do a digital versus a face-to-face, and what does that look like? I think some of that will flow through, but we're not at the point of maturity where we can easily capture and measure that. But I think that's something that we'll get better at as we talk more of a language of environmental impacts. And one thing that I'm really keen on, as part of we do a quality impact assessment and we do an inequality impact assessment, but for any business decisions going forward, we probably need to put in a sustainability impact assessment as well, so that people are using that language every day. So I've waffled a bit there. I'm with you, but I don't think we're there in terms of the maturity of measurement yet to be able to define that in a meaningful way. If that helps.
Thanks, Sarah. Thank you, Andy. I think I would support, Sarah, the proposition that we include sustainability assessment in kind of key strategic decisions. Just a quick observation, which I think follows on what Andy said. We need to be careful, don't we, that we don't run the risk of reducing the trust's CO2 output, but just shifting that output to service users. So there are things that we might do that might reduce our carbon emissions, but might require people to travel further or more often, and therefore we're just displacing it. So we just need to be careful that we take that more kind of holistic view, and that we're not kind of perversely incentivized by the prospect of having to pay for carbon credits by just shifting our emissions to other people. I'm not sure there's an easy answer to that, but we certainly need to be conscious of it. I've got a comment from Mark.
Thanks, Chair. Morning, everyone. So I'm Mark Platts, I'm the Director of Finance and Inflation. Just a quick point on this one, really. Sustainability is really important, but I think as a board and as the wider public, really, we just need to be mindful of the level of investment required to deliver it in terms of financial resources. So I think, as a board, I'd welcome support from all members, really, to start lobbying nationally so that we can get funding for this on a localised basis, so we can actually make some of these plans in here a reality. So I just wanted to throw that in, really, just for consideration. Thanks, Kevin.
Grateful, thank you, Mark. Sarah, did you want to make a comment that you haven't already?
Yeah,
made?
it was just on your point, Kevin, about organisations are being tasked with net zero, and I think a question that I have posed to the regional team that hasn't been quite answered yet is there will inevitably be some netting off, I think. So is it as a system, or is it as a region, or is it as an organisation? Because you couldn't ask each ward to be net zero, for example, versus a community team. So I think there is something, as you say, about law of unintended consequences of one part of the system making a decision having an impact. So it's really good that they are asking for a system plan, and I think there will be the need for a really clear read across in terms of what each organisation is saying and how it might impact on others. So I just wanted to make that point. Thank you.
Grateful. Thank you, Sarah. I've got two more contributions and I'm going to draw this discussion to a conclusion. Jane, you're first.
Thank you, Chair. Jane Marshall, Director of Strategy. I really welcome this, and I think the simplicity of the messages at the start of the document apply to all of us. I just wondered, Sarah, whether there'd be a separate communication plan once this is agreed, and whether that be system or LPFT. But I think there is something quite significant about engaging our service users, particularly young people, in what we're saying as an organisation as part of this green plan. So that was my question, really. Thank you, Chair.
Yeah, you're absolutely right, Jane. And I know Joe's on the board today, so that's definitely a key piece of work going forward. Is, as I sort of said earlier, it's making sure it's at the front of everybody's mind in all business decisions. And people are using the language as well, and something that we wanted to sort of model ourselves on the Lincolnshire County Council framework, which is about personal responsibility as well. This isn't just something that sits over here, it has to be sort of everybody's bread and butter. So absolutely, in terms of comms plan.
Thank you, Sarah. Last question, Philip.
Yes, thank you, Chair. Philip Jackson, Non-Executive Director. Very comprehensive plan, Sarah. It's very, very good, and we'll look forward to monitoring it at the Sustainability Committee meetings. But just one question, really, and it's just on page 14 regarding food and nutrition. I mean, I noticed we're talking there about some procurement of salads and sandwiches and things from ULHT. But I'm just thinking about the wider carbon footprint of food and the fact that, across the greater Lincolnshire footprint, we've probably got one of the biggest areas of the country for food growing, manufacturing and processing. And I just wondered if we could try and do more to ensure that we're actually sourcing food directly from the county of Lincolnshire rather than from other parts of the UK or indeed from abroad.
No, absolutely. I think that's one of the areas of significant opportunity for Lincolnshire. I can't say too much without breaching some commercial sensitivity, but I think absolutely we need to work together as a system. You know, we are the larder of the country, as they say, so we need to make sure that we're sourcing locally wherever possible. And I think as a result of the system working we're doing together as an ICS, that's better facilitated than it has been in the past, shall we say. Thank you.
Thank you, Sarah, and thank you, colleagues. The question then is that does the board approve the plan as presented by Sarah and its submission to NHSE? Yep, that's great. Thank you very much, everyone. Thank you, Sarah. And we'll move on then to item 3.1, which is Anita and the risk register. Thank you, Anita.
Thank you. Can I actually start by apologising? There's some information contained in this risk register that was part of the report that went to ET around the risks waiting for approval. They shouldn't be contained in this report. That was a complete oversight of my part. So those ones awaiting approval, they need to go through Chris and his operational team first before that they come onto this. So for that, I apologise. Oh, sorry, I haven't introduced myself. I'm Anita Lewin. I'm the Director of Nursing, AHPs and Quality. I am presenting the risk report to you. As you will see on this public risk register, there are 16 risks. Since the last time I presented this, we've had no additional risks added to the public risk register, and we actually haven't closed any either. I'm happy to pass over to questions around specific risks. We spoke last time about the alteration of the presentation, and I certainly do think it's a much better document, but we also had a discussion around the scoring, and certainly two of non-executive colleagues agreed to or offered to do some work with us around that. I haven't had the opportunity to take them up on that since the last board meeting, but rest assured you're on my to-do list, and certainly before the next one I will be contacting both Andy and Di. But other than that, I'm happy to pass over to executive colleagues and for questions around any of the specific risks that are contained in the report. So thank you.
Thank you very much, Anita. Do I have any questions or comments for Anita or other exec colleagues? I think Sharon might be shaping up to either ask a question or comment.
Might come in, to be fair. I didn't know if Ananta wanted to give some of the positive updates that didn't meet the risk register from last week. I didn't want to steal the thunder, really. I know Ananta had an incredibly positive day last week in terms of recruitment.
Okay, I'll hand over to Ananta.
Thanks, Anita. Yes, I mean, there's room for cautious optimism, I think. I'm Ananta Dave, Medical Director at LPFT, and we know that recruitment and retention is a nationally challenging issue and really underpins all the work that we need to do. However, within the Medical Directorate, we have been making cautious progress in terms of international recruitment to substantive consultant posts, especially in the tricky areas of older adults, where we've had historically quite a few vacancies of substantive posts, and also about pointing to clinical academic posts, which is a joint post between the University of Lincoln and our trust. So we hope that these will provide more reassurance and provide evidence of LPFT being an attractive place to work where staff are supported appropriately so they can deliver good care. We wait to see how things pan out further in the future, because this is quite a significantly challenging time, but we're making inroads. Thank you.
Thank you, Ananta. I think that was an update well worth hearing, and is very, very encouraging. So thank you for that. Any other questions or comments for Anita or other colleagues? No, Anita, I think it's fair to say, isn't it, that this is still a bit of a work in progress, and you've got some conversations to have with non-exec colleagues around kind of presentation and content. I'm happy to help too if you think that would be helpful. If you want to catch up, risk it's always been one of my hobby horses at my previous trust, and I'm quite happy to continue to be bothered about it now. So if you find that helpful, then give me a shout.
Brilliant, thank you.
If not, then the report's received and noted. Thank you. Let's move on then to item 4.1. Sharon, it's the meetings or the draft minutes of the October Quality Committee.
Yes, thank you. So the draft minutes are here for your information today. I'm not going to go into the detail because at the last board we did have a narrative report on the highlights from the committee, but for good governance the minutes weren't ready last time, so they're here for your information, and I'm happy to answer any questions. Thank you.
Thanks, Sharon. Any comments or questions for Sharon? I don't see any, so thank you very much, Sharon. We'll move on then, and Anita, I think we're back to you, aren't we, for the next item?
We are, thank you. So this is, I'm presenting to you hot off the press really, so released yesterday with the Community Mental Health Survey results. This is a different, for those that have seen us present the Community Mental Health Survey results before, this is a very different paper this time. We have, and it talks about it later in the paper, but I'm going to make reference to it up front really. As an organisation, we've invested in a patient experience lead who started with us 6 weeks ago, and I think this paper demonstrates some of the positive work that is going to come along with the creation of that post. I do think it's worth noting that the survey for next year has actually already taken place. So I'm presenting to you the results of the survey last year, and that is why within the paper it talks about some of our actions being kind of short, medium and longer term, because the survey has already been completed. We do know that the CQC, and it is a CQC regulated survey, has said that they don't think that last year's results are really comparable given kind of the pandemic situation. So they have compared them with 2021 and 2019. I do have to say we have a very good response in terms of the national response rate. We do well with our response rate, so thanks to the teams that support this. I won't go through the details of the paper. You can see the areas where we've scored better than other organisations. You can see the areas where we need to improve. What I will say is there is a lot of rich qualitative data that has been included this time, and we have asked Quality Health to undertake the survey on our behalf to do some analysis of that data. I've booked them in just for people that don't all come to Quality Committee. So we know the Community Mental Health Surveys. For those of us that have been around for some time, this is something we know very well. But I'm conscious that we have a lot of new, certainly non-executive colleagues that potentially don't know the detail of the Community Mental Health Survey. So they are coming to the next Quality Committee. Quality Health, who present and conduct this survey on our behalf, are going to come to Quality Committee in January to just to give a very brief overview of how this is undertaken, but also to give us feedback on the themes and trends that come out of our work and the analysis of the qualitative data to enable us to move forward. So in terms of kind of where we go next, obviously the short-term approach, I've spoken about Quality Health coming to the Quality Committee, and I think really understanding that qualitative data is our key focus over the next 3 months. And as I said, I'm not going to read through the paper. The details of the medium approaches are there, and the longer term work. This isn't something we're going to kind of put right this year, but that's not the right thing. We need to get everybody to understand not only the importance of the survey, but what it is telling us about our service delivery behind it. So I think I am going to just finish there. I'm happy to take any questions, and that's where I'm at, really. I'm happy to take any questions, and then we can discuss if people are happy with the approach going forward.
Thank you very much, Anita. Tim, there's a queue from you in chat, and I don't know whether it's a legacy queue or a queue on this. So
it's a queue on this.
Excellent.
Hi, Anita. Thanks for that. As you say, a very rich and thoughtful document. I've got a question on a bit of the data. So quite rightly pulled out the highlights of where we're outliers in terms of, better than on the benchmarking, and obviously the one area where room for improvement. But the scores, and maybe I'm misunderstanding it, in table where is it? Section page 7, section table 8 and table 9. Whilst we're not outliers in comparison with other organisations, the scoring there is, and maybe I'm misunderstanding it, is quite a bit lower than in the other sort of areas. And in particular, that one score in table 8 is, I wondered if it was actually a misprint or not, but I just wondered if you could comment on it.
And I just think we have commented on some of the scoring because Sarah had raised previously, there were some bits that just didn't seem right. And that's why we're doing the analysis with the qualitative data as well, because some of the scores do seem kind of quite way off, actually, which is why we're doing something very different. And it's only a couple, exactly as you'd said. But I think the analysis of, we've had more qualitative data given this time than ever before, which is why we're kind of investing on the true analysis of that. So if it's, I'm not kind of fudging the question, and I'm happy to answer it, but I'd rather wait to see what the qualitative stuff tells us behind it. And certainly for, I'm hoping by exception from the next quality committee, some of the questions and some of the comments can be raised as part of the quality committee kind of minutes and the reporting up by exception from there.
Yeah, more than happy. I just wondered if there was any immediate comment around those, because it just stood out to me.
Yeah.
But yeah, fully set, an ongoing discussion, as you might say. Thank you.
Thank you. No, I think that's a good idea, Sharon. I was going to say that. So they are starting first. So even if people can't stay for the whole of quality committee, if they don't, kind of, the community survey is kind of a really big issue in mental health trusts. So if people just could join for the first 30 minutes of quality committee.
Yep. Thank you, Anita. So the board's invited to note the outcome of the results and agree the future approach. Are people happy with that? That's great. Thank you, Peter. You've preempted me asking when the next quality committee is, so I wasn't going to do that publicly for fear of making.
You've gone on mute, Kevin.
Yeah, well done. Thank you, Anita. I was going to say I wasn't going to ask publicly for fear of making myself appear more foolish than I normally do, but that's great. Thank you very much. Let's move on then to item 4.3, Anita, which is still with you.
It is, thank you. So this is the report that was published on the 24th of November 2021, which is concentrates on the multi-agency response following the death of Michael in 2015 and Melanie, who was his long-term girlfriend, who was subsequently committed and charged with his murder. So in terms of this report, what I will say is board colleagues will know that I've been presenting a few of these over the course of the last few months. I think it's a good thing that these finally getting published and getting through the process, certainly for the family and friends of people involved in these incidents. They are a long time coming to publication. And I think it shows the commitment of people to really start to speed up some of these processes. It has been too long and protracted, and that isn't acceptable. In terms of this particular one, we had quite a few contacts with Melanie. The report does conclude that it really wouldn't have been possible to predict the death of Michael. However, there were some very clear kind of actions and recommendations for us within Lincolnshire Partnership, and they are listed in this report, which centre around really asking more questions and that professional curiosity, work around the carers, the risk management really, to be fair, left a lot to be desired, and there was more that could have been done. And again, the issues with some of the clinical systems not talking to each other. Now, I have tried within this report to identify some of the areas of development. I've met with the safeguarding team this week because I know there was a discussion at the last board around this professional curiosity, because it's a real concern of mine, and the 3 reports that have come that I've certainly presented over the course of the last few months have mentioned professional curiosity as a key issue, and there's just not pushing and asking more. So I've met with the safeguarding team just to establish how we can check that is happening, because it's quite difficult. It's that how do we know if we don't, how do we know the unknown, how do we know what's been asked? Now, in terms of the safeguarding team, they get a considerable amount of kind of phone calls from staff and conversations from staff when they have cases like Melanie really that come to their attention. What they are saying very clearly is that they can see evidence of the training, they can see evidence of people ringing them, and the safeguarding team aren't having to send staff back to say, you need to ask this, you need to ask this, this is further detail that you need to be getting. So staff are coming with a far more comprehensive kind of overview of the cases that they're dealing with, which would indicate that the major changes we made to training. We do know 2015, 2016, there were a lot of issues around safeguarding in LPFT, and there was a big drive to improve our training and improve the work that was available for the staff. So the reports from the safeguarding team is that they're definitely clear evidence that professional curiosity is really in place now, but we are going to work with operational services just to see how we can strengthen that and how we can provide more assurance around that. The easy one to report on is the link now between Rio and IAPTA. So the link between the 2 clinical systems. So if a patient is open to different services, that actually flashes up on the 2 systems. And I have spoken before, I think some of the carers work that has happened in the organisation that's been led by Donna Bradford and by operational services. And for us as an organisation, our investment in the carers agenda, you know, it is excellent. So I am happy to take any comments on it. It doesn't, you know, it was a sad report to read. You know, yet again, I'm presenting one of these, and as I say, you know, they are from some time ago, but that does not mean that we shouldn't continue to strive to learn from these. And I'm working with the quality and safety team and with safeguarding around all of the learning to make sure that that we don't just kind of say, well, it was 2015. You know, for us it could be yesterday, and it's imperative that we bring these to life and continue to strive to learn from these incidents. So I'm happy to take any comments and questions.
Thank you, Anita. Can I start with a question? Well, I'm not sure that it is a question. There might well be 2 comments, actually. The first is to your point about professional curiosity, and it is, you know, a worryingly consistent theme, even if it is historical. And my sense is that that's as much cultural as it is a training deficit. You know, it's that whole kind of combination of individual competence, first line management, organizational leadership, and the kind of behaviors that the organization encourages and values, isn't it? And we just need to stay on top of that. That's a painting the 4th bridge kind of job, isn't it?
Yeah, absolutely, but it's important that we do.
Yeah, no, it's absolutely critical, and it's not. And I should hasten to say that, you know, it's not a uniquely LPFT problem. You know, you see this written across similar, you know, reviews in other organisations, but it gets to the essence of why we're here and the approach that we want of our professional staff, and it gets to the heart of, for me, what kind of effective leadership is about. And my other comment or observation, Anita, is that is just simply to note the fact that 5 years to produce this is, I'm sure there are good reasons why it's taken 5 years, but it inevitably, and it's not our fault, as it were, that it's taken that long, but it inevitably devalues the conclusions and the lessons that we can learn, and that's well, it is what it is, but it's worth noting that. Chris, I think you've got a comment.
Yeah, thank you, Kevin. Yeah, Chris Higgins, Director of Operations. It was just really picking up the point about professional curiosity, and there's always more that we can do. But I just wanted to emphasise the point that we do some brilliant work in this trust every day, and we've got some expert clinicians that excel in professional curiosity, and that is the bread and butter of what we do, and risk management is our game. And so I just wanted to kind of balance that out, that there's always more we can do. We want to really press that point, but we've got some brilliant people out there doing some brilliant work and who are excellent at professional curiosity, and probably the leaders in the field, I would say.
Chris, I'm really grateful. Thank you for offering that bit of balance. And I didn't mean to imply that we don't do it well and that we don't get it right every day. I think my observation was simply that it's an issue on which you can't sit back and say, well, I've done that. It's something that has to be continually worked at. I'll take a final comment on this from Jane.
Thank you, Chair. Jane Marshall, Director of Strategy. I welcome this report, Anita. I know it makes difficult reading. I just think in the context of integrated care systems, there's a question for me about how we use case studies like this very sad example to demonstrate where more integrated ways of working may not avoid an incident like this, but certainly would maybe help us to identify these really vulnerable people who are at huge risk, aren't they? So I think it is one way we can say that the findings and the learning isn't lost from this tragedy, really, if we use it for good as we move to integrated care systems. Thank you.
Thanks very much, Jane.
On that, I know it wasn't really a question, but I absolutely agree with you, Jane, and I think the way that we are operating now, certainly in the safeguarding arena, and I know, for example, this week Sarah was invited to be part of the Safeguarding Adults Board to present kind of previous cases. I think we are very joined up on this arena, and we're all striving to kind of make sure that we learn. So yes, so I think you're absolutely right. These cases cannot afford to get lost.
No, I'm sure that's absolutely right, Anita. And as you say, it's not an easy report to read. None of these ever are, and it is, absolutely incumbent on us to make sure that those lessons don't get lost, whatever the passage of time, and that they do get played into the wider system. So the board takes note of the report and actions and developments that have happened since the tragic incident. So thank you very much for that, Anita. I'm going to suggest that we take a brief break now. It is, according to my clock, 10:33. So can we take 10 minutes and reconvene at 10:45? Thank you very much. Right, everyone, it is 10:45, so I propose to restart. If everybody's not quite here yet, they'll have to catch up. And we will move straight on to item 6.1. And Philip, that's you and the minutes of the Sustainability Committee.
Yes, thank you, Chair. The minutes for the Sustainability Committee of the 11th of November have been circulated. My apologies for the fact that they didn't go out until yesterday, but obviously we had quite a short turnaround period to get those written and approved and sent through to you. And we've also had the highlights report as well from that meeting of the 11th of November. I won't go over all the points in there, but just to make one or two key points that we did have the outcome of a deeper dive and got substantial assurance around the financial and quality aspects of the Francis Willis unit, which we'd had some concerns about before. And we also, via another deep dive, were party to the action plans to improve the CAM services performance, and again we were satisfied that was moving in the right direction. We also had a look at the revised investment appraisal framework, and we think this will help to improve budget management, business case approval and capital investment decision making, so that's a positive move. We received assurance that the mental health investment standard would continue to be met across Lincolnshire for the remainder of the financial year. And we also had very positive updates on progress with the eradication of dormitory accommodation projects as well. So I think those were the main points that came out of the meeting, but I'm happy to take any comments or questions, Chair.
Thank you very much, Philip. Any comments or questions? I don't see any. Philip, thank you very much. Board notes those minutes, and we'll move on then to item 6.2, Mark, which is the integrated performance report.
Thank you very much, Chair. So good morning, everyone. I'm Mark Platts. I'm the Director of Finance and Information for the Trust, and I present the report as read, and we're going to note any actions that might arise from any discussions through this. So we have got the usual format today, so I'm just going to go through some of the national oversight and trust performance metrics and then hand over to Chris and Jane for focus on the divisional and people sections. So in terms of the national oversight and trust performance metrics sections, I'm only going to focus on a couple today, but I think they're key ones to update with really. So metric 9, which is the early intervention in psychosis 2-week waits. So this is a metric that is off track this month, unfortunately, but the service are reviewing operating processes and are fully aware of that. And I can validate that because myself and Sharon Robson were there for a non-executive director visit with the team yesterday. And I must say I was really impressed with Emma Barris, the team manager, and her approach to trying to get this all back on track. So there was a clear recognition that there is a significant increase in referrals and ongoing staffing vacancies and recruitment challenges are impacting on that service. But actually, there was some really innovative options that we were talking about moving the team forward to meet the demand on that. So whilst not a positive metric in the report, it was a positive outcome. And just sticking with the early intervention in Psychosis team, I just wanted to make a note, having spoken to Emma yesterday, about the great work that the team have done about maintaining the delivery of their physical healthcare checks. So that's been maintained for 2 months now, and there's plans in place to make sure that compliance will remain focused. So it's been a challenge during COVID with isolation requirements and impacts on the team, but Emma's done a great job working on the team to turn that around. So just wanted to note that one. And the second one I was just going to mention was the improving access to psychological therapist services recovery rate, which is metric 15. Again, the team continues to focus on this one. I know this is an area that I've touched on in previous reports, but that there is a continued increase in complexity of referrals that's kind of adding to the demands on the service. And interestingly, following the latest recruit of trainees coming through from university, just nearly 27% of the team are now trainees, which is obviously great for the future sustainability of the service, but does have impacts in terms of supporting those trainees to help service delivery in the immediacy as they start their training placements. So the team are on hand with that and working on that, and we are expected to see some improvements through increased use of effective group sessions and other options moving forward as well. So they're the two main areas of focus on the national oversight metrics. So if there is any questions, happy to take them on that. Otherwise, I'm going to hand over to Chris, if that's okay.
Thanks, Mark. Any questions for Mark before Chris does his bit? I don't see any, so crack on, Chris.
Lovely, thank you. Thanks, Mark. So just really in summary of the operational sections, the divisional sections, you'll see a picture of staffing pressures across multiple service lines with vacancies and also staff absences due to sickness and COVID related isolations. You'll also see a picture of demand across multiple service lines that appears in the main to be linked to COVID and what was previously described as a kind of mental health surge in activity, and we're seeing that surge coming through across a number of different areas, and both those things combined are leading to demand outstripping capacity on some areas, which is a particular challenge. Most notably, which we've referenced before, is the autism assessments for diagnosis of autism and children and young people services, and there's actions being put in place, action plans to address those, and the last item, the Sustainability Committee highlights report, referenced some of the assurance being provided for children and young people services there. You'll also see a picture of new investment into services. So through working with commissioners, we've agreed investment across a number of service lines, which will increase capacity and help to reduce waiting times in some areas, and also see that a significant amount of transformations going off across services. Obviously, the adult community mental health transformation is part of that, but there's transformation across other areas to try to increase capacity, increase productivity, but a real emphasis on integration and collaboration with system partners, and a real emphasis on working with our community and voluntary services sector as partners in care. You'll also see in there some references to transformation around digital working and embracing digital working, building on the success and learning that we've had through the pandemic. Most notably, I'd say, is the memory assessment digital pathway in the older people and frailty division, which is a new launch of a new pathway to get more access for people. So lots going off. New investments to try to meet the growing demand, but I'd say in summary, our greatest challenge to operational performance at the moment is the availability of staff through particularly recruitment to vacant posts, but also retaining people when they start work with us. So happy to take any questions, and I'll leave it there.
Thanks, Chris. And I'm my observation, and it's something that I've said before, and Jane will recognise this comment. I would like to be able to see much more clearly the link between vacancy rates and performance. So for my money, that needs to be presented, graphically, in a way that means that we've got a clear line of sight into those services where performance is being affected by staffing, and then we can then go on and look at whether or not we've got the recruitment pipeline that meets those issues. But Jane, that's that's a priority for me, and I also know that that's work in progress. So you know, don't necessarily need a detailed response to that this morning, but I think there's a degree of urgency around giving us that view into the link between workforce and performance that at the moment we don't currently have, and I feel vulnerable, you know, on behalf of the board as a result of that. But thank you, Chris. And you know, generally the picture of performance in all the circumstances is really creditable, and you know, on behalf of the board, really grateful for the work that's being done, you know, to sustain that performance in, you know, difficult circumstances. So thank you for that. Jane, let's move on to the people part of the report.
Thank you, Chair. Jane Marshall here. I wonder if colleagues have got some comments and questions, Chair, from the chat. You're on mute, Chair, sorry.
Sorry, I had spotted that, Jane, but let's move on with the people part first, then I'll wrap up questions and comments at the end. Thank you.
Thank you very much. So Jane Marshall, Director of Strategy and People, here to present the People section, which is from pages 28 and 29 in this Integrated Performance Report. And to pick up the comment you just made, Chair, about the triangulation of some of the significant risks that my colleagues have spoken around the people agenda, so sickness absence, turnover rates amongst our staff, vacancies and retention. That will all come together in a presentation that will come to our board development session in December, when we will map what we consider to be our fragile services, as you've just described, Chair, against where our vacancies are. Key to that, and this is described on page 29, is work that we are all doing to make sure that the data we hold about our staff are as accurate as we can make them. And there is a significant piece of data cleansing work that we've been undertaking over the last few months. The results of that will be reported into the People Committee that will meet next Thursday, so the 9th of December. So by the 16th, I think we'll have, when we meet as a board in development session, we'll have a very much clearer picture of where those risks sit in service lines. But you're absolutely right to say that it's a significant challenge for us. My colleagues Chris Higgins and Mark Platts have already set that out as part of this report. We are being innovative and creative where we can to recruit. So, for example, my board colleagues will know this, we have 10 international nurse recruits joining the organisation from the end of November. My colleague Ananta Dave has, the medical director at the Trust, has spoken earlier in the meeting about medical recruitment and some green shoots around recruiting consultant medical and other medical grades into the organisation, but it does remain a significant challenge and risk for us. And I'm really happy to take questions. We are doing a lot of creative work inside our organisation. We're linking with system colleagues. We are taking opportunities for funds that are becoming available from Health Education England and NHS England, and all of that is having an impact and a positive impact on our work, but it remains a risky position for us. Thank you.
Thank you very much, Jane. So questions or comments, please. I've got Sharon first.
Thank you, Chair. Jane's addressed some of my question. So I do welcome, Jane, that triangulation that you've just talked about, because whilst we do need that data around vacancy rates, for example, and agency rates and underperformance, that's not going to capture all the work that staff are doing to ensure performance, but with, you know, very stretched conditions. You know, staff are working roles that additional hours, and obviously that's putting stress on them. So there are all those kind of softer data around how they're managing it, how they're reviewing their pathways, as we found out yesterday, myself and Mark, all the work that's going on in every individual service to maintain performance, which without that triangulation won't show. And I just wanted to commend the work that the executive team and others are doing in terms of maintaining performance during the surge, but I've also got a question about whether that surge is temporary or long term, because I've heard from services how the makeup of the patients that they're seeing is different to the way it was pre-COVID. So the demography of their client population has changed.
Thanks, Sharon. Andy.
Sorry, thank you, Chair. Andy Spring, non-exec director. It probably builds slightly on Sharon's point. So my comment is we have a number of indicators in adult services, to me, between indicators 43 and 54 that show service under pressure, certainly from my reading of it. And what I'm wondering, and I've heard the good work that people are doing in terms of trying to maintain performance and what we're trying to do to recruit, etc. I just wondered what we can do as a board that we're not already doing, what the executive team need from us to help support them, and when will we know at what point, if you like, this becomes critical and a tipping point, and what measures we're using to kind of make that assessment. I hope that makes sense.
Yeah, that made sense to me. Chris, do you want to come back on that?
Yeah, just picking up the 2 points there, really. From first point from Sharon around demand, I think what we're planning in operational services is that the demand that we're seeing now is what we're going to be living with for some time to come, and we're not expecting it to be a surge that subsides. It's a surge that potentially will even continue to grow as the pandemic continues. And so I think where we're working with Commission is really to make sure that all the resource that's committed in the long-term plan is filtered through to frontline services where it should be, and we've got some of that, but not all of it, and so we need to work with commissioners to be able to ensure that the money gets into the right place. There's then the secondary challenge of recruiting the staff to be able to, with that resource, so that we can provide the services, but both elements are needed to get that right. But I think we need to accept that this is probably going to how things are for some time to come in terms of demand. Pick up Andy's points there. I think the key metrics for us to look at as a board are probably around the metrics 50 to kind of 55 in terms of there's probably the other ones are really important in terms of number of incidents. They're probably in line with what we would normally expect on acute admissions wards and benchmark probably reasonably well with other wards of a similar nature in other trusts. It's those bits, the warning signs for us are things like clinical and management supervision, where there just isn't enough time to get them done on a shift, and they're the things that slip. And so we can see there, in particular the adult inpatient division this month, is we know they're struggling to keep up with those supervisions because the cost of staff availability, and that's an issue. There's always a balance to be struck in terms of what we aim to do. Is first and foremost is minimum safe staffing levels. What that doesn't account for is minimum optimum staffing levels, and I think there's just some work probably through People Committee we can look at in terms of what's the difference between the two. Safe staffing is one measure, but actually it's optimum, where we can make sure that we've got all the therapeutic interventions delivered and all the supervisions, appraisals and things are also being able to be delivered as well. So I think we just need to look at probably those both sides, optimum versus and safe as well.
Thank you, Chris, for those comments. Sarah.
Thank you. Just to build on what Chris said, really, and something that we've been discussing as an executive team is it's really hard to explain eloquently, but everybody's sort of working perhaps a lower level than they should be, because we've got ward managers who are filling shifts on the front line, so we've got service leads who are doing ward manager, you've got associate directors, so we're all sort of being, rightly so, making sure that services keep running safely and effectively. The glimmer of hope, I think, is we've had some key appointments made lately in terms of our suicide prevention lead, our clinical investigators, our patient experience lead as well, and it just puts that bit of capacity in really to keep going with our transformation and our learning and our lessons learned to make sure that we're running services even more safely and effectively going forward. So I guess what I'm saying is it might get worse before it gets better, but there are some key bits of additional capacity that we've had the foresight to say actually we need to invest in these, and they're already starting to make some great improvements. I think it ties back to some of the safeguarding review reports that we've had at the board recently. So I just wanted to share that thinking. Thank you.
Thank you, Sarah. Tim.
Thanks, Kevin. Sorry, it's going back a little bit, but I think it's an important question, and it relates to your comment around and Jane's comment around the data and getting to the point of understanding links, etc., recruitment pipeline, etc. I guess my question is simple, because sort of recognizing there are so many pressures from different areas, it's a prioritization of resource, etc. I guess is there a way around capacity and maybe capability, because some of it may be specialist, around getting that data sorted out and in place? Can we accelerate further on the hard work that's already been done?
Thank you, Tim. Jane Marshall here. If I could respond to that as Director of Strategy and People, I think by the 9th of December, the next People Committee, which of course, Tim, you chair, we will be able to show significant progress on that data cleansing. I've driven that really purposefully, and it's that granularity that we absolutely need. We have been able to make sure we have granularity in one of our riskiest services, the adult inpatient division, which we've obviously highlighted. And if you have the granular detail, you can then plan your workforce absolutely as we should be able to. And that point about the tipping point that our chair made, with the work that we did in inpatient services, we were able to analyse the data, act on those gaps where we had them, be creative and innovative, bring people in. And we then did a review of that through the Director of Operations, just to test whether we were safe enough in our provision, and it passed the test, at least in the short term. It doesn't alter the fact we've got loads more to do, but we know that we can do it in some of our riskiest services. And the People Committee next week will have that granularity, which we will then talk about as a board in development on the board development session we have in December. So I'm absolutely determined we will have that information as a board. It will, even if it's only 85% accurate, it will be good enough for us to really be able to plan our workforce effectively. But that doesn't take away the risk and the challenge that we have in terms of people being out there to recruit. That obviously is a difficulty for all. Social care for the NHS for all employers at the moment, but we will get that level of granularity. Thank you.
Thanks, Jane. I'll look forward to that conversation next week.
Thank you, Tim. Thank you, Jane. Mark.
Thanks, Chair. I won't repeat a lot of what Jane said, really, but just from the business intelligence and the digital side of things, that's definitely something that we're aware of, and we have invested in the team, and we have actually managed to recruit to some posts to bolster that up. So one thing that I've been really keen on is that we can get this data and we can start to use it using the teams that we have in place, rather than necessarily bringing in someone external to design and shape and set these things up. So we are looking at that, and we have been working the closest we've ever worked with the people function over the last 6 months, really, to get that right. So you will start to see the benefits coming through from that. Thank you.
Thank you very much, Mark. Do we want to stay with you, Mark, for the financial elements of the report?
Excellent, thank you very much, Chair. So yeah, I'll just close talking through the sustainability and the finance elements of the report. So if I just focus on our operational financial performance, you'll see by the number of zeros on the top couple of lines there that we are continuing to meet our financial targets. So we are breaking even, as an organisation and as a system, which is positive. One thing just to note for board's awareness, really, we have only last week submitted our plan for the remainder of the financial year. Acutely aware that we are 2 months into it now. So from next month's board report, we'll be reporting against that revised plan submission that we're working on. So although we do look like we're breaking even at the minute, we'll be reporting against that updated position from next month, so that'll be increased relevance for us. Just picking up on a couple of points that Sharon made and came out quite heavily in that last discussion, really. I do just want to note we are continually reliant on the use of bank and agency staffing. So we're forecasting our agency spend to be over £3 million this year, which is the highest I remember in the organisation, to be honest. So it all links nicely in with the conversations that we're having and that reliance on temporary resource that we need to be mindful of. In terms of capital investment, as we all see when we go to the supermarkets, it continues to be a challenge working with the market conditions and keeping our builds on track. We are now forecasting a £6 million lower achievement of our capital investment for the financial year. The majority of this, to be honest, is driven by our Norton Lease scheme in Boston, where we were initially planning to start that this year, but getting the designs right and working with NHS England and improvement around final business case authorisation, that's slightly delayed now. So we are looking to start work on site from October 2022. The current plans at the minute will still enable us to meet the required deadline for the March 2024 opening. So a little bit of a delay, but we are using that slippage that we have in that mandate for eradication of dormitories over in Boston. So whilst it's not great news, I do just want to say to board and public, for those that are on the Lincoln County site anytime soon up in Lincoln, please have a walk around our work that's going on with the eradication dormitory schemes up on that site. Absolutely motoring through the progression now. We've got steel frames up and we've actually got a roof on the north building now that's really starting to take shape. So I think the proactive work of the project team in ordering materials in early and getting stocking is really coming to benefit the scheme on the Lincoln County site. So there is a little positive end there, really. So happy to take any questions on the sustainability financial elements, but other than that, that's the report of the December's board meeting. Thanks, Kevin.
Thank you very much, Mark, and for colleagues for taking us through that with the usual care and attention, and thank you for the comprehensive nature of the report. Are there any questions on the financial element of it? When there's nothing in there, Mark, that's surprising. So from that respect, you know, it's what's the word? An unexceptional report. That's great. Thank you very much, everyone. I think we've given that a good discussion. So let's move on then to the report, the annual report of the charitable fund, annual charitable report. I'll get the words out in the right order. The annual charitable funds report. Philip.
Yes, thank you, Chair. Philip Jackson, Non-Executive Director, and here with one of my other hats on as Chair of the Lincolnshire NHS Charity. And you've got the annual or a summary of the annual report in front of you this morning. Just a reminder, this is a joint charitable funds committee for our trust and for Lincolnshire Community Health Services Trust, and the report you've got this morning is an abbreviated version of the one that goes to the Charity Commission on an annual basis. Obviously, we're registered with the Charities Commission, so it sets out some of the main things that we've been doing over the last year, and also the main aspects of the finances. You'll see that in terms of the charitable funds held, it's roughly a 80-20 split between LCHS and our trust. So the LCHS is by far the bigger part of the financial amounts that are held in the charity. And I guess the report talks about how money has been spent in our trust this year, and also money that has come in. Quite a large chunk of the money this year came in from the Captain Tom fundraising as part of the COVID fundraising, which was distributed to charitable funds around the country via the NHS Charities Together. So that was a large part of the income for this past year, and that money continues to come in and will continue to be spent over the next year or so. So I'm happy to take any questions anybody might have on the report.
Thank you, Philip. Really grateful for the report. Any questions or comments? No, I don't see any. So thank you very much, Philip. The board notes that report, and I think we're still with you for the annual report of the Sustainability Committee.
Yes, thanks, Chair. Yes, with my Sustainability Chair hat on this time. This is the first annual report of the Sustainability Committee. I'm assuming everybody will have read it. Don't intend to say much about it, only it does show I think we've had a successful first year meeting our objectives, and I think a very good basis for taking the committee forward. Happy to take any comments or questions.
Thank you, Philip. Any questions or comments on the Sustainability Committee annual report? Again, I don't see any. Thank you, Philip. The board notes that report. Let's move on then to item 7.2, which Ananta is you.
Thanks, Kevin. Hello, everyone. Ananta Dave here, Medical Director at LPFT. And this is a statement which is normally presented annually to the board, which is the AOA, the Annual Organizational Audit and Statement of Compliance, which relates to the status of appraisal and revalidation for doctors, for medical staff within the trust. The information is presented in the report, which I hope people have been able to have a look at. Happy to take any questions. It talks about the alterations made to the annual organizational audit and statement of compliance in the wake of COVID-19. The new arrangements came into effect last year, which were brought in by the National Medical Director, Stephen Powis, and which were in place till July this year. And they mainly related to the deferment of appraisals and revalidation for medical staff as a result of the pressures of the pandemic. And therefore, during this period, although there was no requirement for people to submit their appraisals or get revalidated if they were due to be revalidated before July 2021, as an organization, we encouraged medical staff to carry on with their appraisals as much as they could and collect all the information required for appraisals and revalidation. So from August 2021, this year, after the pandemic rules stopped and people were asked to get on with their appraisals and revalidation and the usual time scales were resumed, we have been steadily increasing the numbers of medical staff who've been having their appraisals, and we hope to be on track with revalidations at the end of this year, that is March 2022. So therefore, this report gives the numerical data about the numbers of doctors in the organization who are said to have a prescribed connection, that is for whom I'm the responsible officer and they work within LPFT and for whom I would be expected to make recommendations around appraisal and revalidation. It also gives a template, the attached report, which is about the statement of compliance, gives a template of the annual organizational audit, which would normally have been submitted, but which was not this year due to the requirements being stood down. But this is the template that are the kind of questions that we would be asked to answer as an organization to see if we are keeping up to date with appraisal and revalidation requirements. Happy to take any questions or clarify anything that is presented in the report. Thank you.
Thank you, Ananta. There are two things we need to do here, I think, aren't there? The first is to note the contents of your report, but the board specifically has to endorse the statement of compliance on page 12 of the attachment. That's right, isn't it?
Yes, that's right, indeed.
Thank you. Thank you. So I have a comment from Peter.
So Kevin, it's Peter Halley, Trust Secretary. I think you've probably just covered it, Kevin. Just to make the clear point, you will need to sign on behalf of the board the compliance statement on page 12. Even if we're not required to submit it, good governance would say that you should sign it off on behalf of the board.
Yep. Got that. Thank you.
Thank you.
Tim.
Hi, Tim Harry, non-exec. Ananta, thanks very much for the report. Obviously, really critical, important area. There was just one point I just wondered if you could sort of elaborate a little bit on, which is providing evidence around getting feedback from patients periodically. I just wondered what that actually meant, you know, sort of periodically, what determines when, etc.
Yeah, so essentially this is 360-degree feedback or multi-source feedback that all doctors are required to undertake as part of their annual appraisal and revalidation. Now, there is definitely a requirement to have at least one comprehensive external feedback. So this is a feedback undertaken independently by an external organization, most commonly by the Royal College of Psychiatrists, or the GMC has its own external feedback template. So at least once in a revalidation cycle, all doctors would be expected to get an external revalidation. And this is determined by so the organization which is doing it, so they would determine the number of patients, they would contact the patients independently without the doctor having to do it, and it would be collected by this independent organization and a chart and a narrative produced. Apart from that, internally within the organization, we encourage all doctors to have a 360-degree feedback. So from within the trust, so this is administered by the trust and completed by trust colleagues and, you know, looked at by the appraiser. So that is what we mean by 360-degree feedback, and it consists of patients, carers, multidisciplinary colleagues, and whoever else, you know, supervisors, anyone else that the doctor might have worked with during the course of that year or revalidation cycle. Now, part of the requirements, I mean, part of this was obviously a bit affected during the pandemic due to the rapid adaptation of digital working, for instance, or the pressures. So not everyone was able to complete the 360-degree requirements in the way that we would expect them to. This was also part of the reason why doctors were allowed to defer their appraisal and revalidation requirements. So that is what it refers to. Thank you.
Yeah, thanks for that, Ananta. That gives me more assurance. That's really helpful. Thank you.
Thanks, Tim. So to the question then that the board confirms the statement of compliance in the annex to Ananta's report. Are people happy that I should sign on behalf of the board to that effect? Good. Thank you very much. Thank you for the report, Ananta. We are, I think, in the home straight. Peter, I think the next item is the forthcoming board agenda.
Kevin, just to confirm, the paper is there. There are no changes to the paper. Just to note, anything going forward next year will, as to whether it's online or in person, will be subject to risk assessments as those risk assessments shift and change. Other than that, that is the board agenda going forward, and if I just say at the same time, there's no consent agenda items, and from a self-certification point of view, nothing had come up that would affect self-certification. That covers all of that.
Grateful. Thank you, Peter. You preempted me asking you that. I don't have any notification of any other business. Peter, do you?
No, we've no other business for the part 1 meeting.
Excellent, thank you. It's been a really good meeting. We've had some really high quality discussion around some important issues, and I'm grateful to colleagues for contributing. Thank you very much. Now, my proposal is we're due to meet for part 2 in private, that we take a short break so that people can make themselves a cup of tea or whatever, and we start again at 20 to 12, and we'll progress some of the agenda and then see where we get to before we break for lunch. People happy with that?
Yeah, thank you.
Great stuff. Thank you very much, everyone.
Thank you.
Thank you.